Hi everyone, and welcome to the webinar on um, child wasting programming in response and preparation to the COVID-19 pandemic, experiences from the field. I want to thank everyone for coming on time and being here, and so I will start on time while people I'm sure will continue to join us. Before I start, I want to introduce myself. My name is Andy Kendall. I'm the program director for the TechRRT, the Technical Rapid Response Team. Can everyone hear me all right? Just to give a little yes. Okay, got a yes from someone. That's good enough. Great. With that, I'd like to jump in to our webinar today. Before I start, I just want to make sure to let you know that we will be recording the webinar so that we can share this broadly with other colleagues who are not able to join. That has already started. Today's webinar is brought to you by, can we go back to the first slide, please? Thank you, the title slide. Okay, it's brought to you by the TechRRT in collaboration with the GTAM, as part of the GTAM, and with ENN and UNICEF, as well as various others. Basically, there is a Wasting Global Thematic Working Group, which has recently taken shape under the building of the GTAM, the Global Technical Assistance Mechanism for Nutrition. This global thematic working group is being co-chaired by UNICEF and ENN, and it's just really ramping up to start to be able to handle questions that are being escalated from the GTAM, and this webinar is a joint effort of all of these people, these groups. The webinar today is going to have collaboration not only with those organizations, but also case studies that will be shared from Save the Children, with a case study coming from Kenya, World Vision with a case study coming from Bangladesh, and one from Goal in Ethiopia. We also, at the beginning of the webinar, will have a small technical component that Johns Hopkins is bringing to us from the Center for Humanitarian Health. Okay, Geraldine, can you please go to the next slide? So first, I'd like to go through the webinar, the objectives of the webinar today. Basically, we know that the coronavirus has recently come as a big surprise to all of us, and we have had to change and adapt to the context. Therefore, we would first like to communicate details of a recently published brief on the management of child wasting in the context of COVID-19. This came out just about a week ago now, and it will be being regularly updated. The second objective is to illustrate some challenges that are faced and adjustments that are already being put in place for programming on wasting in preparation for or in response to the COVID-19 pandemic. Finally, the idea is to really give practitioners a space to be able to talk about questions and to understand how we can improve nutrition programming in response to the COVID outbreak. Yeah, just really those are the main objectives, and hopefully we'll get plenty of space to work on the third objective. We try to have at least a half an hour, hopefully 40 minutes for that. Can I go on to the next slide, please? Great. So today's webinar, first we have this welcome and an overview and the introductions. Just after this, oh, hang on just a second. There we go. I don't know. Okay. Hopefully just after this, you will, sorry, I just lost my train of thought because my screen went off. Okay, but we're back now. So we're going to have an overview of the recently released brief on the COVID and child wasting management. This was put out, as I said, about 10 days ago, about a week ago, and it is being updated, and we will have the case studies and we will have a Q&A. We will also have a technical brief that we're going to start everything off with. Before we go into the introductions, which is where I started to say, I wanted to make sure that everyone that's on the call right now, except for the presenters, to please turn off your videos and turn off your microphones. We can do this in the bottom left-hand corner of your screen. There's a little microphone and there's a video button. If you can all just make sure they're on mute and the video is stopped. I will let you know that if they are not, we will mute them and stop the videos. The idea is really to make sure that everyone can hear well and that people with low bandwidth are still able to take advantage of the webinar. So we appreciate your cooperation for this. We also, we have, as everybody has already been doing, please introduce yourselves in the chat box. I know lots of people have done it already, but please continue to do so. If you can put in there your name, your organization, and what country you're calling into us today from, that would be great. If you have questions during the webinar, please, or input or comments, whatever, please do enter those into that chat box. Those will be compiled, and during the Q&A session at the end, those will be, somebody will be compiling them. Somebody is Colleen, who I'll be introducing in just a second. She'll be compiling them and pulling out questions from different groups that are coming out. And if your questions are not answered during the call today, if we don't have the time, don't worry, those questions are going into the process for compiling questions, and they will go into updating of the next brief. So please put your questions, even if there's not going to be time to respond to them all. As I mentioned before, the webinar is recorded, and we have an evaluation that we do at the end of the webinar. It's going to be a link to a SurveyMonkey. On average, it takes people about 6 minutes to fill it in. This helps to make our webinars better and also allows you to put in some topics that maybe you are interested to have on another webinar. So please do go to that link at the end of the webinar and give us your feedback. With that, can we go to the next slide? Wonderful. Okay, you probably already see me right now, but I'm Andy Kendall. I'm the Program Director of the Technical Rapid Response Team. I'm going to hand over to each of the presenters as we go for them to introduce themselves. Over to you, Maya.
Good day, everybody. I'm Mija-Tesse Ververs. I'm Senior Associate at the Johns Hopkins University Center for Humanitarian Health, and I work for CDC as well.
Thanks, Maya. Is Saul on the line? I didn't see him earlier, but hopefully he's joined us in the meantime. If not, I will go ahead and introduce Saul. Saul Guerrero, he's a nutrition specialist for care for children with severe acute malnutrition. He works for UNICEF in the program division in New York. Over to you, Mjabuli, to introduce yourself.
Thank you. My name is Mjabuli Jamela. I work with World Vision in Bangladesh under the Refugee Response Program. Thank you.
Thank you. Over to you, James.
All right. Thank you. Thank you so much. Yes, I am James Njiru. I work for Save the Children as a nutrition specialist in Kenya. Thank you.
Hi, and my name's Hatty Barthorp. I work as Global Nutrition Advisor for Goal based in the UK.
And hi, everyone. My name is Colleen Emary. I'm a technical advisor for health and nutrition for World Vision International, and I'm based in Canada.
Wonderful. Thank you all for presenting yourselves. Over to the next slide. Wonderful. With that, I'm going to jump right into our session because we do have a full packed agenda today. So I'm over to you, Maya, for the quick technical brief. Some of you may have been on our webinar that we hosted on Monday. This is, in fact, actually a series of webinars. We started out with the webinar on Monday that was on COVID and infant and young child feeding. And so Maya actually did parts of this presentation that day. We decided it was important to give a bit of a grounding in the what is known technically about COVID to be able to have a productive webinar today. So we asked her to repeat at least some of the slides. So apologies for those of you who are with us on Monday. Before we go on, just to mention that after this set of webinars that is in English, we are looking to do these webinars as well in French, Spanish, and Arabic. So please do watch your emails over the coming days to see when those will be. Also, we will be reaching out proactively looking for field experiences as more countries start to implement adaptations to programming. If you're interested to have your experience highlighted, please do send us an email, share with us your experiences so that we can consider including in one of the webinars. Okay, over to you, Maya, to start off. Thank you.
Thank you. Thank you. Next slide, please. So I will talk very briefly. It's not a complete repeat of Monday's webinar, really about the disease and how it affects children, the transmission, and what it does that the science tells us at the moment. Just a disclaimer very quickly. I was asked yesterday, so I couldn't update it until yesterday. This is what was known until the 4th of April, and it's designed for a global audience. Next, please. So very briefly about the transmission, what we know so far. There are two ways of transmitting COVID, the coronavirus. And it depends a bit how it's transmitted on the size of the particles. If it's a bigger particle, then it's more the respiratory droplets. If it's a very small particle, then it's a droplet nuclei. I will explain that in the next slide. So the first one, if they're bigger droplets, then you can say it's like fluids. So COVID-19 virus probably is transmitted mostly between people through respiratory droplets, those bigger ones like fluids and contact routes. So when a person is in close contact with someone who has respiratory symptoms and possibly has the disease through coughing or sneezing, those infective droplets can enter somebody else's body via the mouth or the nose or the eyes. But it's also possible that you transmit through objects. You hold your hand on utensils, doorknobs, toys, or clothes. So if you're in the immediate environment of an infected person, it's likely that these kind of fluids are on those objects. Next slide. However, it is also possible, but we don't know exactly to what extent, that the very small particles, the droplet nuclei, airborne, that they can remain in the air for longer periods and therefore can be transmitted to others over distances greater than just 1 meter. So in the context of COVID-19, this airborne transmission is possibly more in a clinical setting for what we know, at least, like where you have intubation, ventilator use, or resuscitation of a COVID-affected person. But I must say the last word has not been said about this yet, because there will be further studies needed to determine whether this is really a possible way and what the extent is of this transmission rate. Next. So just a slide on children versus adults. How are they affected? So far, we know that the severe infection of COVID is characterized by a massive inflammatory response. We call it the cytokine storm. Cytokines are substances what we use in a normal immune response. So that's normal. However, with the COVID, we've seen that it's kind of a storm, and it's in an overdrive, and therefore it results in respiratory distress or multi-organ dysfunctions. Now, inflammatory responses in adults and children differ and vary over a lifespan. That's what we know. but this inflammatory response might be actually less with children. Now, why would they be having this less extent of inflammatory response? Maybe because they have less exposure, maybe they still have relatively immature immune response, or they have a decreased likelihood of the illness being infected. So we don't know exactly. Just to tell you that from a study in China amongst over 72,000 cases, only 1% was less than 10 years. Next, please. So there's a lot of research and publication going on. And what I say now might be outdated in 3 days, but a lot of the trials are also related to treatment and vaccines. And there's also now more publications about the demographics, who is affected and where and why. Next, please. So what do we know about COVID-19 in the children is that many people are asymptomatic or pre-symptomatic, but they still can transmit the disease, including children. There was one study in China that said that 13% of the confirmed COVID children were asymptomatic, so you don't know whether they have it. In general, children are mostly asymptomatic, have mild or moderate symptoms. Now, from those studies I found until last Sunday was that the case fatality rate in China was only 0.2% for all those affected under 40 years old. So it's a small group. In the USA data, I found that 1% was under 54 years. But again, what I said, there's new studies, and I hope to update this another time. Now, there's one study in China about over 2,000 children that looked at about a third that were confirmed and 2/3 were suspected. And that study caused a lot of row, I think, because it says young children, particularly infants, were vulnerable to COVID. And they said that the proportion of the severe cases were 11% was under 1 year. However, I must here stress that more of the critical cases were amongst the suspected. So we don't know whether they have COVID. And these children could have well been infected with something else and had another respiratory disease. So we question actually for the moment until further notice the results of this study. Next, please. So this is the one before last slide. What is still not clear? We don't know how malnourished children are affected by COVID-19, by the virus. We know that, of course, malnourished children have more problems with a good immunity response. I think it will become clear the coming months, weeks even. We don't know whether skin-to-skin contact, like young children and mothers, is there any transmission risk? We don't know whether the virus is inactivated by heat or cold. What does freezing do, or high temperatures? What are safe alternatives to masks? Can the virus appear in breast milk many weeks later after the mother has recovered? So for the older children that still breastfeed, are they at risk? What are safe ways of disinfecting masks? And we don't know yet the programmatic evidence. What is the best way to deliver now safely the CMAN programs in a COVID context? For feces, we know that the virus can be present, but until now I've read mostly that there are particles of the virus in feces. It doesn't necessarily mean that you can get the disease from stools from a child. So just, and there are many, many more questions. Next, my last slide. So what I've decided is for Hopkins to create this site where we will hopefully from tomorrow onwards have all the peer-reviewed journals tell us about these subjects, COVID-19, children and nutrition. So it will be an overview, all what we know, and we have to, it's like a repository, and the latest will be first mentioned on the site. So we hope to give you in this way a snapshot if you want to keep track of all what we now learn over the last months, but also in the coming days. You can go there and we will update it every 3-4 days, so you know the latest. Thank you.
Thank you so much, Maya. That was fantastic. I hope that gave us all a good grounding of what's actually known and what's not known, and super helpful resource that Johns Hopkins is looking to lead, and much appreciated. Okay, now normally we would be going on to an overview of the brief that came out several days ago. At the moment, Saul is the person who was going to present. He is not on the call, I believe. Saul, just to reach out, just to make sure you're not there. I believe you are not. Okay. So we could go to our case studies first, in hopes that Saul will come on. However, I'm going to ask out loud, Marie, as the co-chair of the Wasting Global Thematic Working Group, would I be able to ask you to present the brief using Saul's slides in the meantime? I don't know if we're able to. Ben, would you be able to unmute?
I have unmuted Marie.
Okay, Marie, if you're okay with that, great. If you're not, please just say, and we'll go on to the other other presentations first.
Well, just I'm happy to help, but this brief was produced by UNICEF and the core team who coordinated it, rather than the technical working group. Right. So I think it probably would be best if perhaps if you dive ahead, and I could do a quick orientation at the end, perhaps when I've orientated myself again back onto it. But I think perhaps moving on might be the best.
Okay. Alternately, before we go to that option, I just wanted to see if somebody from UNICEF who's had a hand in the brief is available. That would be, do have lots of people from UNICEF on the line.
Andy, maybe they can message me directly, and then we'll sort it out before the end. I'm the host, Ben Allen, if there is anyone there. Thank you.
Okay, with that, let's go on. And now I'm going to hand over to World Vision and to Mjabuli to do their presentation on the experiences from the Rohingya refugee response. Over to you, Mjabuli. Thank you.
Thank you very much for having me. I'm with World Vision in Bangladesh, and part of the Rohingya refugee responses has been said. So I'll just take you through our experiences in the past maybe month or so, trying to adapt our program to in a context where COVID is present. So our adaptation started when we had our first case in Bangladesh, and I'll be taking you through them. Next page, please. Yeah, so a little bit of our context. We have more than 850,000 Rohingya refugees living in a very small part of Bangladesh, closer to the border with Myanmar, in 34 camps that are overcrowded. So the general population density of Bangladesh is about 1,500 persons per square kilometer. But when you go to the Rohingya camps, the population density is about 40,000 persons per square kilometer. Actually, we know that in some of the places it's as high as 70,000 people per square meter. So that is super crowded. And in those camps also, there is limited health infrastructure, shared sanitary facilities, unhygienic living conditions. You have, sometimes you see sewer flowing in the camps. General, I would say, poor health-seeking behaviors. And also, we know that from the reports, we know that there is elevated prevalence of acute respiratory infections. We're talking around 170,000 cases reported since January. And this is from a WHO source published on the 20th of March last month. And also, as of yesterday, 218 confirmed cases were in Bangladesh, including 20 deaths and 33 that it's recovered. So we have local transmission within Bangladesh. Next slide, please. Next slide, please. Oh, sorry. Can we go? Can we? Okay. We'll just continue. Sorry, I lost my flow there. Can we go a
Mjabuli,
slide
if you would like, yeah, if you'd like to go back, go ahead.
Yes, a slide back. Yes, thank you. So far, no cases of COVID have been reported in the camps, but some studies showed that there is limited awareness within the refugee camps, where like there was 407 listening groups, and out of those 407, only 1.2 talked about COVID. So that's very much of a big concern. Also, there is a concern of limited, while there is limited awareness, also there is limited internet coverage and sometimes limited network reception, which is a challenge when you're trying to send information. And also low testing remains a concern. In a country of 165 million, we're talking about 1,900 people had been tested as of 2nd of April. So that becomes a concern. And also, while there is low testing, WHO and the health partners are trying their best to put up systems for testing, and they're also training health workers in terms of COVID so that they can be prepared. Next slide, please. Okay, so maybe as we zero into what maybe most of you are interested in today, some of the adjustments that we started doing about a month ago when Bangladesh had its first cases was to adjust our screening methodology from the normal active case finding, which is done at household level, and we shifted to family MOAC, whereby mothers are trained on MOAC and they're able to measure children within their households. And also for blanket supplementary feeding, our targeted supplementary feeding and OTP, we reduced the frequency of follow-up visits to bi-monthly for BSFP, monthly for TSFP, and also we are working on transitioning to monthly for OTP, anticipating that access might be a challenge as we go ahead. One thing that I have to underscore is these adaptations are done in coordination with the nutrition sector in Cox's Bazar and involve all the nutrition partners. So we are kind of like working together to come up with a common approach, a standardized approach as it were. And then in terms of group meetings, IYCF and behavior change communication groups were suspended, and all activities that required maybe mothers to come together. It could be IYCF support groups. It could be all different methodologies that are behavior change oriented that required people to come together. All of those are suspended. And then house-to-house activities are suspended as well in an effort to promote social distancing. Next slide, please. So we also worked on modifying our workflow, which basically we tried to mark standing points in order to maintain social distancing. We engaged and used more volunteers to assist with crowd control. So in terms of marking our standing points, we kind of like mark on the floor with paint so that one beneficiary knows, the beneficiaries know that they have to stand at that particular marked point so as to maintain social distancing. And then also we reduced the number of points within our workflow. We had places we were trying to expose our beneficiaries as much as possible to health promotion. So we had a station for health promotion. We also had another station for cooking demonstrations. So we had to remove those stations so that people spend less time in the centers. And this has also yielded positive results in the sense that in January, our average time from arrival to the center to a time the beneficiary leaves the center was 55 minutes. But as of now, it's around 20 minutes. We're still working hard to try and reduce that time. And then also, in terms of volunteers, we are increasing our reliance on Rohingya volunteers as the number of staff that can access the camp are being reduced. And also, we had also volunteers from the host community who we're working with. But as time goes on, their access to the camps is also being limited. So that means we'll rely more on the Rohingya volunteers, and some of the duties that we are trying to have these volunteers participate or lead out in include training mothers on family work, registration, like the basic clerical work that we do of registering beneficiaries, recording their mid-upper arm circumferences and food distributions. And also, we also raise awareness. We're trying to come up with many innovative ways, also respecting social distancing. We're bringing in megaphones, use of televisions as part of our awareness sessions. And then in terms of IPC measures, we've brought in hand washing facilities in almost every room in the nutrition centers. We have hand washing facility at the entry point, which then means everyone who's going into the center, whether it's a beneficiary, it's a staff, it's a volunteer, they have to wash their hands, and there's someone stationed there to particularly monitor that. Wash their hands for at least 20 seconds with soap and water and clean water, which we provide. We're providing hand sanitizers for our staff in the different stations so that they're able to sanitize. So this is it's a new culture and it's a new practice. So we try and as much as possible to have someone to be monitoring this to make sure that it is happening. Next slide, please. To the challenges, while the government is trying to control and avoid the spread or the importation of COVID into the case, as it were, we are seeing the limitations in terms of humanitarian access. During the current lockdown, most like the numbers of humanitarian workers allowed into the camps was reduced, and we expect or we project that it will continue to reduce as the situation develops. So, which is a challenge on our side. And then how high population density and shared services make social distancing impractical. For example, ladies have to go and fetch water from the water point. It's shared. The sanitary facilities are also shared, and the Rohingya rely a lot on food distributions, so they still have to go to those places which are relatively crowded, and making social distancing impractical in most cases. And then also there is an aspect of poor phone and internet coverage, and also even access to mobile phones amongst our community, which kind of like limits our ability to leverage technologies such as mHealth solutions within our programming. Local modification local modification criteria, which is currently under being rolled out. For us is specifically MAM is between 12.5 and 13.5. So this one is coming up with a unique challenge that our MOAC tapes are already marked at 12.5 and at 11.5 with the different color codes, as you know. So in a context of low literacy, it is then difficult to explain to the mothers about the 13.5. Next slide, please. So the modifications as well may lead to increased length of stay. I use the word may because we just started 30 days ago and we have not really calculated, but it may lead to increased length of stay and reduced average rate of weight gain because persons are staying longer in the program. And then also, it is not possible. We had come up with an idea to say, let us, in order to promote social distancing, let us have nutrition centers and sub-centers which are going to help us decongest. But it is very difficult because of space and also because of staffing limitations, especially given the context of the shrinking humanitarian access. So those are the challenges that we faced. Next slide, please. Oh, thank you. That was my last slide. Thank you.
Wonderful. Thank you so much, Mjabuli, for your presentation. Fantastic to see how the approaches that you've been using that include some nudge approach, as we talked about on a recent webinar for social behavior change, so that people know what the distance is that they need to be standing. Very interesting. Thank you for that. We're going to go over, we're running behind time now. I would like to present the next case study. It's by Save the Children from James Njiru. It's from Kenya. And James, I'd just like to remind you, you've got 10 minutes for your presentation, and we do need to catch up time as well. So I'm going to hand over right away. Thank you, James, over to you.
Thank you so much. I will try to save time. Yeah, my name is James Njiru. I'm working for Save the Children as a nutrition specialist in Kenya. I'm going to take you through the context in Kenya for COVID-19. And I'm also going to give you some recent adaptations that are being considered, that have been either implemented and have been lined up for implementation for treatment of acute malnutrition in this environment. Next slide. Good. As of yesterday, Kenya has confirmed 179 cases, and one case is mild and one case is severe. The others are either mild or moderate. In terms of age breakdown, we have seen 3 cases are aged below 15 years. We have 49 cases that are aged between 15 and 29. 114 cases are from individuals aged 30 to 59 years, and then 13 cases are above 60 years. In terms of testing, so far the country has tested 5,278 samples from individuals who have been a history of either having been in contact or have traveled, and majority of these are from quarantine facilities. And out of that, 2,000 contacts have been tested. And we have so far been able to discharge 578, 1,426, and we are currently following up 578. So far, in the last 2 days, there has been pronouncement of strict measures by government. Currently, there is no movement outside one county to another. There has been a mandatory wearing of masks, especially if you are visiting public places like supermarket or using public transport. In addition to infection prevention measures like social distancing, washing hands, and using sanitizers. So in line with that, we have seen even delivery of health services, including treatment of acute malnutrition, has been largely affected because with no gatherings, even our outreach services, which are largely very beneficial and useful in arid and semi-arid areas where populations are far from health facilities, they usually benefit from outreaches. So even outreaches have been limited. In other counties, that has been banned completely. So access to healthcare has been largely affected. So with that, there has been ongoing discussions on modifications. The implementing partners like civil societies and Save the Children have already gone ahead to do immediate modifications on the ongoing projects to continue providing life-saving interventions. And some of these proposals that I'm going to present, some are being implemented and others are already being considered for nationwide implementation. Next slide. Good. COVID, the first case was recorded in Kenya last month, like beginning of March. And the opportunity here is the country already had community interventions already being either piloted or on scale up. For example, we already have a favorable policy environment around community health engagement, and we have community health volunteers allowed to do certain interventions, though not all. But in this case, under the ICCM or Integrated Community Case Management, so CHVs are allowed to treat diarrhea, malaria, and refer pneumonia, and refer acute malnutrition. But there has been on small scale where they have been trained to treat acute malnutrition and also pneumonia, but that was not a nationwide program. It was localized in some counties. We had also had pilot research and then pilot, and now we are on scale up of family work, where mothers had been in different counties have been trained and issued with work tips to screen their own children. And so that has already been on scale up. So these interventions had already gotten buy-in from the government, and therefore it has become easier to include them into the program guidance that between last week and this week is what is being released for use in the country in terms of these adaptations. So you realize that the family work tools that are in use is a modified work tip that is slightly broader than the normal or regular work tip. This is designed to improve the accuracy, because we all know that the narrow the work tip is, the easier it is to dig into skin and therefore the broader it is, then it becomes less likely to dig into skin because of the tension. Again,
James,
it has, yes.
I'm sorry to interrupt, but we're going to have to, we've actually run out of time and we're going to need to go more quickly. Would you be able to just jump through quite quickly, please? Your next slide.
Thank you. Thank you. Next slide. Great. So this I've already mentioned of the 3 approaches that have been considered and have already been mainstreamed in certain areas of the country. But what you are seeing on this slide is the modification or simplification processes that we went through in the treatment of acute malnutrition by community health workers. And this, they are able to effectively use these tools with ease compared to what was existing in the ICCM work previously. Let's proceed. Great. So in the modification, we saw that increasing or dividing the normal color bands from work tape increases sensitivity of work tape. So those are colors that you can see that mean the CHVs are able to or do follow-up for treatment of acute malnutrition, and they are able to tell how the progression of treatment is happening. So you can see even the dosage was simplified into the dots that you can see on the Salter scale represents the sachets that CHV gives upon putting the child on the weighing scale. And then in terms of calculating the dosage for either 1 week, 7 days dosage, or 14 days for moderate acute malnutrition, then they use a simplified dosage calculator. So these icons have been very, very useful, and low retrate CHVs are able to use them. Proceed. Great.
If you
so
could just do a very quick overview of this, that would be much appreciated. Apologies to have to ask that.
So I have touched slightly on this, but we have realized that use of colors and use of icons that are contextualized makes it simpler for CHVs to use these tools because we saw improved recovery rates, we saw increase in treatment coverage, and then we also saw involvement of the communities to have better social accountability on commodities, especially RUTF. So for family work, we have seen it is pretty feasible and easier because mothers accessed treatment early, and the households were able to even report that to the community health volunteers who relayed that information to the national information system. So moving forward, what we have included in the national guidance now that is being released by the government is inclusion of these interventions. So the challenges that we are anticipating, for example, is for scale up of family work, is how to train mothers with without gatherings, without community gatherings. So, but we are working around innovations like use of simplified voice messages and also small clips that can be used at community level. So I think that's next slide. Great. So basically for us, that's what we have been able to do. But this is still work that is ongoing in terms of scaling up these interventions. Thank you so much.
Thank you so much, James. We very appreciate you sharing your experiences so far in Kenya. I'm going to move very quickly on to Hatty from GOL and the experience that they're having in Ethiopia. After that, we'll go on to Saul with the presentation of the brief itself. Over to you, Hattie, and please try to be brief if you can. Thank you.
Can we go to the next slide, please? So first, I just wanted to give everyone a recap of the malnutrition in numbers in Ethiopia, just as an overview. So we've got around 28% of child deaths are associated with undernutrition. 37% of children are stunted, 21% are underweight, 7.2% of under 5 suffer from stunting, and we've got 22% of women of reproductive age who are undernourished. So the Ethiopian Intercluster Preparation and Response Plan estimates that there's going to be about a 30% increase in individuals with SAM and MAM in Q3 compared to the original estimates for this year, and 20% in Q4. So what they're looking at is potentially an additional 70,000 children affected by SAM and almost 500,000 children and PLWs affected by MAM. And it's expected that the existing health system capacity can only probably reach around 50% of these cases. Next slide, please. So in terms of COVID in the context of Ethiopia, the index case was on the 13th of March, so that'll be a month ago tomorrow. As of Tuesday, they had 44 confirmed cases, 2 deaths, 4 recovered. There were an additional 10 cases yesterday. It's currently in 4 out of the 9 regions, and testing's carried out in 4 centres, but there are plans to have 3 centres per region, and the Ethiopian Public Health Institute are approving those. There are also private centres that are going to be opened up prospectively. The coordinating body for acute malnutrition is the Ethiopian Nutrition Coordination Unit, the ENCU. And the current restrictions that are applied in country are that government employees all have to work from home where possible. There are travel restrictions using any public transport, and that's applied to all regions. Public gatherings, large markets, meetings have been restricted, and there's mandatory isolation for incoming travellers for 2 weeks in Addis. The airport's still open at the moment. Next slide, please. So in terms of acute malnutrition programme prep, from a federal regional administrative perspective, the CMAM task force that's been convened by the ENCU, the Ethiopian Nutrition Coordination Unit, they've been working on adapting global guidance to fit the Ethiopian context. So what they've done so far is they've developed a 6-page doc called the Emergency Nutrition Programming Recommendations for COVID. And the current version that's being used is from the 1st of April, but there are regular updates planned for that. The purpose of the document is to provide recommended adjustments for life-saving nutrition services, the identification and referral of acute malnutrition, and interventions aimed at protecting adequate maternal, infant and young child nutrition. So the document covers MIYCN, maternal, infant and young child nutrition, community mobilization and screening, IPC in OTP and TSFP. There's no guidance for SC at the moment, and the management adaptations at all 3 service points. So in terms of the global guidance sources that the Ethiopian government have used, there's no inconsistencies noted between the different guidance, because what they did is they've selected guidance from each specific area. So there's one piece of guidance from food distributions, one for clinical, one for IYCF, one for wasting. But there are more up-to-date guidance briefs now available, but they're still using those initial ones that came out. With regards to goal-specific prep, we've shared a summary note to all of our project staff, and meetings are being held with the regional, zonal and Warada officials regarding programme adaptations. But as and when new or modified guidance emerges, it'll be provided by the Ethiopian Technical Working Group to all of the partners. But what is evident, however, is that although the guidance is planned to be updated on a regular basis, there is a risk that updates might be lost because people are incredibly busy at the moment operationalizing the initial guidance. So my sense is that any significant changes will need quite a bit of investment in flagging and then getting further modifications made to programs. Next slide, please. So in terms of response actions thus far, there's been a stop on all trainings, workshops, meetings, non-essential survey and assessments. No cooking demonstrations, mother-to-mother groups, mother-child pairs are limited to less than 10 at health facilities and TSFPs, but maternal child health services will be maintained, including vaccinations. And just quickly to note, although growth monitoring is part of the national programme, so it will be upheld as part of the MCH, maternal child health services, it acts more like an opportunistic screening when parents present at a health facility for other reasons. So in terms of maternal, infant and young child nutrition, the guidance recommends continued breastfeeding with or without COVID, and there are key IPC messages promoted as per the IYCF guidance that we currently have. With regards to community mobilisation and screening, it's proposed community health workers will continue to screen groups of less than 20 people, employing social distancing, hand washing, use of PPE with symptomatic patients, alcohol-based sanitisation of MUACs, and they're going to use print and audio key public health messages. There's already a package of IEC materials developed, which is available. Re-IPC for services, there'll be temperature checkpoints, space management of 2 meters, dissemination of key IPC messages again, reduced contact where feasible, plus there's also going to be decentralization and staggering of distributions. There are plans to use double rations, hygiene kit distributions are planned, and there'll be separate areas for inpatients with and without COVID in stabilization centres. So with regards to goal on the right-hand side of the slide, we're going to follow government guidelines, plus we're going to support the MIYCN by upscaling the use of community mobilisers using the community-led action approach, which is similar to a kind of care group cascade approach as a mechanism for risk communication and community engagement. The community mobilisers will be recommended by local leaderships. They'll be trusted, respected, with experience of facilitating community discussions. And they will have to be available and willing to visit small neighbourhood units within the community. They'll start by prioritising key health and IPC messages, but then that resource, if we want to term them as such, can be opened up to other key messages, and that will include the MIYCN messaging and addressing myths and misconceptions around COVID. In terms of management adaptation, goal staff in refugee contexts have been told they can admit based on visual assessment if carers are unhappy to touch. Otherwise, people are still screening with the PPE kit. Double rations are only planned where we've established that there will be adequate RUF supplies. And the newly released Ethiopian response plan to accompany the emergency programme recommendations, I've been informed that this designates UNICEF in Ethiopia as the lead agency for coordinating pre-positioning of RUF commodities, but it's still very much in its infancy. So some of you might have seen that I've skipped over the community mobilisation screening. At present, the Ethiopian response plan does not include the family MUAC approach, despite UNICEF guidance through the #1 brief advocating for such. In Ethiopia, UNICEF, the Federal Ministry of Health, USAID, and the World Health Organization have said, and I'm quoting, the family MUAC approach cannot be established now as there are limitations due to the COVID-19 outbreak and trainings are now being suspended. However, we can make a commitment that as soon as the situation returns to normal, the CMAM Technical Working Group will make sure that this approach is piloted in Ethiopia so that the approach to increase early identification and referral of SAM cases can be adopted. So the technical forum does not recommend the piloting of the family MUAC at this stage. So GOAL have asked for this to be revised as we believe it can be achieved whilst respecting social distancing and IPC measures merely by adapting trainings. From our experience of working in the Ebola 2016 outbreak, we used modalities such as the community-led action approach I was just talking about a minute ago to maintain community engagement throughout the crisis. Thus, it would provide a platform for trainings to occur, either through practical demonstrations, respecting social distancing, or using short videos and displayed on tablets or phones. There are obviously other options depending on the context, thus we hope that this will be revised in Ethiopia. Next slide, please. This is my last slide, and I just want to outline some of the challenges that I've been made aware of. So the regional, zonal and Warada level coordination platforms impaired, have been, their ability to have meetings has been impaired because they have been asked to work from home. Virtual meetings are very, very difficult, especially in regional settings in Ethiopia. In terms of community, they are scared. They're wary of outsiders, including our project staff, which is why the community engagement aspect is so critical in this response. In terms of health providers, they're becoming frustrated due to lack of adequate PPE. Government guidance has been stating that health facility staff should be provided with masks, gloves and goggles. With those in direct contact with positive patients, will have much more comprehensive attire. However, many only have gloves or gloves and masks, and there's also been reports of complaints around the quality of equipment available, so the provision of non-surgical poor quality latex gloves. We're hearing also that staff are worried as they've been watching what's happening in other countries on social media, etc. And they've seen examples of frontline health workers contracting COVID, thus propagating concern. And lastly, there's no clear allocation yet of roles by the government to NGOs. Thus, to date, it's been happening a little bit ad hoc, which is probably to be expected given the rate which this has been advancing. So GOAL have been developing their own response plans based on the global and national guidance and the Ethiopian Public Health Institute regional rapid response plans. Thank you.
Wonderful. Thank you so much for that, Hattie. I think we've got a really good example of a very different situation where we've got than we've had on the other two examples. Thank you for that. Now we've gone a little bit out of order, but I think we're okay. Now we would like to actually go to Saul Guerrero, who will present the actual brief that's been put out about a week, 10 days ago. Over to you, Saul, keeping in mind that we've got 10 minutes or less. We're actually running behind, so whatever time we can gain, we add to question and answer time. Thank you.
Great. Thank you. And good morning and good afternoon, everybody. First slide, please. The question, of course, is why did we put this brief together, given that we already have programmatic guidance for the management of wasting. And as the three previous presentations have shown, even in the absence of a brief, most program implementers are already making modifications depending on their context and their capacities. Next slide. The short answer to why we put a brief together is twofold. The first bit, right, is that regardless of the level of mobility restrictions that we're facing around the world, whether you have countries that were still, people are allowed or able to move around, or whether they are on full lockdown, there is a range of actions that need to be urgently taken in order to ensure the continuity of services for the management of child waste. So regardless of your context, there are new things that need to be done. And the second critical thing, and I think the group chat on the side of Zoom today demonstrates that there is an urgent need to start identifying and prioritizing key information and evidence gaps that will affect how we adapt services for the management of child wasting. Next. So if there is a brief, why are we here, right? And shouldn't I just tell you to go read it? Next. The answer is yes, absolutely. Go read it. That is the most important thing. You know, listen to me, but also more importantly, read the thing, because that's why it's there. But the real reason why we felt it was helpful to have a conversation in the brief today is so that you understand why the brief says what it says, why the content is what it is, but also to start getting some feedback, because one of the critical things about this brief, as well as with the IYCF brief, is that these will be updated on a regular basis. We cannot take just a snapshot of what we know and make recommendations right now and hope that those are going to be relevant you know, for weeks and months to come. We made a commitment that we, as the evidence and the practices continue to evolve, we would update those briefs. Next. So As I said before, regardless of the population mobility restrictions, there are actions that need to be taken in order to continue the continuity or ensure the continuity of services. So the way we basically went about doing it was we took the management of wasting into its two sort of broad components. The inpatient services and the outpatient community-based services. And for each of those, we basically tried to consider two separate scenarios. One where there was no population mobility restriction, where communities were still able to move relatively freely, and then a scenario where there was partial or full population mobility restriction. However, as we did that, it became apparent to us that regardless of the population mobility restrictions, when it came to inpatient services, some of the recommendations had to be one and the same. So basically what I'm about to present to you is those three blue boxes in there and the content that we had. Next. So on the inpatient services, I am not going to go one by one through this because I think all of you are in a position to just read through it. And as I said, that's what the brief is for, but I'll just give you a general sense of what the points we're trying to convey and the critical issues that we were trying to highlight. First is that there are already recommended hygiene and safety measures, and that those need to be being enforced, and that needs to be our number one priority, is to make sure that that applies to, you know, the cleaning protocols, but also limiting the contact with healthcare workers. The critical thing as well was making sure that we were supporting mothers in and ensuring strong hygiene standards in the handling of infants under 6 months and all the feeding equipment. Increasingly, and to the degree that it was possible, we wanted to start making sure that we were maximizing the space, the physical space between the beds and stabilization centers, recognizing that, of course, in many of these stabilization centers, spaces is at a premium, but to the degree that it's possible, we wanted to start issuing recommendations to start spacing that out regardless of the number of confirmed cases in a given context. Secondly, to start encouraging reduced family member visits to primary caregivers only. Very often, you know, you have people bringing in stuff and different family members coming in and out, which under normal circumstances we fully appreciate and support. But I think in the current circumstances, we wanted to start highlighting the need to start reducing that, and to the degree that it was possible, once again, to start also encouraging practitioners to start separating patient areas for suspected and confirmed cases from the non-cases, so that we could actually start creating two separate categories within those stabilization centers. Next slide. On the outpatient services, I mean, there's quite a few recommendations here. So again, I'll just go through them. In context where there is no population mobility restriction, we felt that we were still starting to take measures to start building the capacity. Well, first of all, that we needed to start protecting healthcare workers and increasingly start building their capacity when it came to IPC. Where, whenever possible, and wherever services are available, we were encouraging the provision of treatment for moderate wasting, applying the standard IPC measures, but reducing the frequency of follow-up visits from 1 to every 4 weeks for children, and just primarily by increasing the take-home ration, and for the provision of services, also for outpatient days, to start considering shifting, instead of having one single day a week where there is OTPs going on, to potentially having more days, so that the number of people per site per day would be reduced. But the critical part of that, of course, is that the increase in numbers has to be accompanied by even more careful application of the IPC measures on those days, and increasingly starting to increase the capacity of caregivers. And I think that this is a point that was highlighted by many of the presenters before, to start having their own MUAC tapes and mothers doing their own MUAC readings as well as their ODMA assessments in front of the health practitioners to reduce the risk of cross-infection. Next. Now, in preparation for a potential disruption in the ability both of people to move freely, but in the potential disruption to the health system and health facility capacity to deliver services as usual, we were recommending or wanted to start highlighting the urgent need to start building the capacity of community health workers to treat uncomplicated wasting by introducing some of the simplified treatment protocols and approaches that have been explored in other contexts. The same is start initiating, if it hasn't already happened, or intensified trainings for caregivers and community members on the use of MUAC. This has been highlighted, I think, in the context of both Kenya and Ethiopia as being either something that is possible or something that is not so easy to do. But but the reality is that at the very least, we wanted people to start exploring whether there was a way of intensifying or initiating it, given the challenges in each context. To the degree that it was possible, continue the provision of preventative food supplementation and hygiene kits for children and pregnant and lactating women. Again, to start mitigating the effect on the number of children ultimately becoming malnourished and women becoming malnourished. And the same for the continued provision of preventative food supplementation. Next. Now, when there is partial full population mobility restrictions, everything that I've just mentioned would apply, but we would go even further. And we would say that at that point, our recommendation is that we, whenever possible, but what we mean by that, whenever there is a CHW or community health platform that can be used to start trying to deliver all treatment for our complicated wasting in the community, or any other community-based platform via the CHWs or community-based platforms, and using a limited or no-touch simplified approach to do so. There has been an awful lot of requests for clarity on what is the standard or the adapted protocol that should be used in those conditions. The challenge with that is that there isn't an agreed protocol, and for the foreseeable future, there won't be a single adapted protocol for doing that. So instead, what felt critical to us was to start highlighting some of the options that program implementers could explore, and that included using a simplified admission criteria, for example, MUAC and UDIMA only, using an expanded admission criteria, so moving away from 11.5 and moving perhaps to 120 or 125 MUAC and or UDIMA. And I think that this was the point that was also highlighted in some of the previous presentations. The second bit, of course, is adopting a simplified ready-to-use food dosage. And I think that there have been previous examples of this being used with one sachet, for example, of RUTF for uncomplicated moderates and 2 sachets per day for uncomplicated severe. So that kind of simplified model that would enable this to be streamlined and reduce the time and the capacity of all the implications on the health system. But also the big point that we wanted to start making sure that we also recognize is that if this is going to be shifted or added to the community health workers platform, we needed to make sure that this came with appropriate remuneration. I mean, this is no surprise to anybody who has worked in community health, but in this particular circumstances where there's going to be a lot of pressure and a lot of competing priorities, we need to make sure that that shift doesn't happen in the absence of any consideration for the remuneration of CHWs in that context. Next. And finally, we made 2 additional recommendations. One, to reduce the frequency of follow-ups, as we had recommended in the case of moderate acute malnutrition, to reduce it to once per month for children with uncomplicated, severe, or moderate wasting, again, by increasing the take-home ration. If all services are indeed ultimately suspended, to distribute rations for up to 8 weeks at a time. We recognize, of course, the risks of this for many of these households, and the risk that in a severely food insecure context, that will inject a significant amount of ready-to-use food into a household, and the challenge of ensuring that all of that ration goes to the child most in need will be an issue. But we simply cannot find an alternative way of ensuring that we can continue to stand that we have one mechanism to provide that household with the necessary commodities if indeed all services are suspended. Again, same, reducing the frequency of the provision of specialized nutrition foods or other preventative supplementation to children and PLWs, again, to once per month. Just trying to minimize the number, but recognizing that, again, that we might face a situation in a not too distant future where even sustaining that will be really hard. Next. Now, this, as I said, is based on the best possible evidence that we had at the time of writing. But of course, in crafting that, there were more questions than there were answers. And so, when we look at what some of the evidence gaps that we need to resolve before we're able to provide more detail or further guidance, I wanted to sort of show you very briefly some of the main questions that have been identified in that brief, which again, in many ways echo some of the questions that have been mentioned in the group chat. Next. I won't go one by one, but I'll just leave that for a minute for a few seconds. And that just gives you a sense of sort of the range of questions that we include, but a lot of them have to do less with the science of the disease and the virus, but more to do with the programmatic implications of it, and how do we start trying to acknowledge what we know and reflect it in the way that we program. Next. That's all. Thank you very much.
Thank you so much, Saul. Very useful and appreciated, I'm sure, by everyone. On that note, I want to take a minute to recognize that we're about 15 minutes behind now. So we're going to change the order slightly, and I'm going to ask everyone's permission or take the opportunity, as everyone is here, more than 340 people from all over the world: India, Nepal, Venezuela, DRC, Afghanistan, Myanmar, Ghana, just to name a few. I want to take the opportunity to keep us and actually give us the space to have a good question and answer session. Therefore, we're going to go 15 minutes extra in this. I realize that some people will have to drop off. Therefore, I'm going to first tell you that we need to how you can request support, and then we're going to go to the Q&A session. That way, everybody, whether you have to go or not, is able to know how to keep asking questions, how to get additional support, and then we'll be able to go to the questions. That way, if anybody has to drop off, no problems. So how can you get support? There are different types of support needed. You might want remote support or in-country technical support. Okay, right now with restriction and mobility, in-country technical support has to be very creative, but there are possibilities with people maybe in country already, etc. But if you can, there are providers through the TechRRT, Technical Rapid Response Team, or others through the GTAM that we are developing more ways to access them. It's possible to hire a consultant directly. The GTAM has established consultant rosters. There are 5 different rosters in lots of different technical areas, and you're able to pop a request to see if you can get recommendations on a consultant who would be able to fit your needs. If you want to have just quick technical advice, there are the GNC help desks that are available. All of these support possibilities are culminated and brought together by the Global Technical Assistance Mechanism for Nutrition, or the GTAM, and in the website for the GTAM is currently in process of being built. But in the meantime, if you want to contact, please go to the link that's written here, which is the Nutrition Cluster website, and you'll be able to get the support that you require. There is a form there to fill out if you want any of these types of support. Okay, now I want to go quickly to our Q&A, recognizing how Saul has emphasized the need for programmatic implications of all the questions that are coming in. How do we adapt? How do we adapt? So let's go to those questions. I'm handing over to Colleen Emary from World Vision, also part of the GTAM core team, to facilitate that session. Over to you, Colleen.
Great, thanks Andy, and thanks to all the presenters for what you shared today. So as we've been going through this webinar, I've been trying to gather your questions and group them into categories so that we can proceed in a sensible manner here. So I hope I have been able to do that. But what I want to start off with is the family MUAC, questions related to that. There were a lot of questions that came in regard to that intervention. And so to start us off, maybe I can ask MJ from Cox's Bazar to just share a little bit. The question is, how did you train the mothers or family on taking MUAC measurements, considering the need to provide space and actually be physically apart? Where did you do that training? How did you do it? Do you have any guidance in how to train mothers in a way that would adhere to the social distancing guidelines that are in place?
Thank you very much for the question. Like I said, most of what we do or we presented is a joint collaboration of ideas from the different partners. So what we basically did is we, as World Vision, we're training mothers in groups of 5 to 10. It's a continuous process. We have not trained all, but whenever they come to the facility, we train groups of 5 to 10. We maintain the social distancing. So we're afraid to make the groups bigger because it's a little bit difficult to do that. But ideally, it would have been good to do this before there are outbreaks or before we have this kind of restrictions that are there. In a nutshell, I would say that is my answer.
And to add to that, for anyone on our panel, have any of you had any experience using video clips or other types of mechanisms to train mothers on MUAC? And if so, do you think that that approach would be useful in this current pandemic? Hatty, do you want to take a stab at that one, or sorry, go ahead.
Yeah, this is James. Yeah, in Kenya, we had developed a video on how for mothers to take MUAC, and there were different lengths. So there were shorter versions that could be shared on phone, and there were other versions that were displayed in the videos within the health facilities, in the waiting bay, and also in any other available platform within the community. So those videos were very helpful, and because they were developed with the local mothers, so when they do that on video, so mothers used to appreciate very much. And the other one is the short voice message. We realized because of the illiteracy levels, so mothers could not respond to text messages. So we worked with the service provider to have a recorded short voice message that is sent to their most basic mobile phones, and they could listen to that message. So it also helped us to, one, remind them to take more measurements, and also to continue supporting them on how to do that. So those two strategies worked very well for Kenya. But that was done within the pilot context, and that's what now is being considered for scale up, because it was already seen to work.
Thanks, James. Again, still on the topic of family MUAC and using MUAC, there's a question that came in about what's the advice on using alcohol-based solutions to sanitize the tapes between usage. There was a question that someone heard that it was not recommended because the alcohol-based solution could damage the tape, so use of soap should be used instead. I've also heard other advice that we shouldn't be using a MUAC tape on multiple children. So Saul, do you want to provide a comment on that?
Should I?
Sure, yeah, Saul.
Yeah, and then I think some of the other ones will probably want to weigh in. So I think that the recommendation right now is that our primary approach should be to try to provide every single mother with her own MUAC band, precisely to not have to have this conversation about the hygienic or the best way to ensure the hygiene of the tape. We recognize, however, that in order for that to happen, there's got to be a significant amount of MUAC tapes available already, and that will be an issue. So my sense is that if it cannot happen, right, and that should continue to be our primary objective, but if that cannot happen, we do have to make do with what we've got, and that if that is having a single MUAC tape that is held by the community health worker, you are going to have to sanitize it one way or the other. I understand that precisely the risk associated with cleaning it with an alcohol-based solution. It will eventually damage the tape. If that is possible, because there is indeed alcohol-based solutions, I think that generally that is the preferred approach, because a MUAC tape can probably replace, and if you have, but I think that the reality is that there's also going to be shortages of alcohol-based solutions in a lot of facilities, right? And so I think that we need to also be mindful of that. So if the only thing that you're then left with is the possibility of washing it with soap, well, I think that is a third line of defense. which is preferable than no line of defense at all, but it should probably not be the number one if you have access to either alcohol-based solutions as or even better for every mother to have her own MUAC ban.
Thanks, Saul. Anyone else on the panel want to weigh in on that?
No, maybe just to say that it's completely doable to do the family MUAC approach, and it can be done either door to door, or it can be done in group settings, respecting social distancing. So what we've done is we've come up with little schematics for CMAM, for family MUAC, for our social behaviour change activities, to show people how they can actually maintain interaction with communities whilst respecting social distancing. So there's a little channel for people to come in and register with a 2-metre separation, which is what we're using. Then there's a hand washing station. Then they go and stand in each one of these 10 boxes. So we've capped it at a maximum of 10 mother-child pairs if they can come with their child. And then they exit, they profile back out, hand washing again, having taken their MUACs, which are already pre-positioned in their slots. Or it can be done face-to-face, again, respecting the social distancing. So the tape can be left and handed over, and there can either be verbal communication, or you can use a sort of 2-minute, there's quite a few of them on the internet, but you'd probably want to record your own sort of 2-minute video guide on a tablet or a phone, which again can be left near the door if maybe you haven't got the capacity of health workers to disseminate the message in the right way. So it could, you just have to think a little bit creatively about how you can achieve it, but it's certainly doable.
Thanks, Hattie. Related to that, there's many questions that came in on how the process of family MUAC actually works, and how do we validate the measures that the mother takes. So start that question off. It was, okay, so a mother finds her child is yellow or red or pink, if using the tapes that James described. In the context of COVID, where does she go now? Are we still telling her to go to the health center? And then the second part of that question is, how do we, or what's the step to validate that MUAC measurement that the caregiver took? So I invite any of you on the panel that are implementing family MUAC to just talk through that process. I think it would help the people attending this webinar to just understand the process a bit better. So MJ, maybe you want to start with that one?
Yes, thank you very much. While I was watching the questions, I think someone also from Bangladesh tried to answer that question. So basically, we have mothers who see their child in yellow or red. They come to the nutrition center. In our context, we have standalone nutrition centers. And then at the nutrition centers, as part of what we still maintain to measure is we retake that MUAC also. But also one thing that is special about our context, we're also working in a context of blanket supplementary feeding. So the mothers at one point or the other have to come to the center, and when they get to the center, we reconfirm the MUAC. Thank you.
Thanks for that. So I'm going to move us on from the family MUAC. I know that there was a lot of questions there. I do encourage people to go to the, there's a community of practice on family MUAC, which the link was shared in the chat, and there are resources there. Some of the simplified tools that were shared by James, for example, the color-coded MUAC tapes are explained there as well. So, but I'm going to move us on because there were other topics that that came in. The next group of questions refer to how COVID-19, how the actual disease looks in SAM in the case where a child has SAM. So we know that one of the, as shared by Maya, one of the signs of COVID-19 when it gets to be quite severe is you actually get the cytokine storm. So the question was asked, in children with SAM, do we expect to see the same type of clinical features as a child without SAM? Maya, I'm wondering if I can put that question to you. I recognize there's not a lot of evidence on this, but it would be good to hear your thoughts.
Yeah, thank you for that question. It's a good question. I do not have the answer. I only can say that what I meant about the cytokine storm, this massive inflammatory response, there's much more to say. There are other reasons why older people have more are more affected, because there's something about the receptor in cells but the virus uses to enter the cells, and some of these receptors are more present in older people or with a certain comorbidity like diabetes or cardiovascular diseases, so they can enter the cell easier, replicate more. So there's so much more to say about it. I kept it fairly simple. I'm sorry about that. So I don't know how this is going to work out, and we will know, sadly, we will know quite soon. And therefore case reporting is very important. Whoever sees this pathology in a community where there are relatively more acutely malnourished children and see how this evolves would be really good to report on.
Colleen, can I say a couple of things?
Please.
Yeah, so just, I mean, I agree with Maya. I don't think that there is an awful lot of evidence right now. I am maybe less confident that we will have that evidence available to us right away, because I think that the availability of testing at scale in that kind of context will continue to be a challenge. If it's a challenge worldwide, I imagine that there will be a challenge. And I think given the ARIs and pneumonia are such a common comorbidity of waste, amongst waste children, I think that using, I'm not really sure how we're going to arrive at a proxy that will help us separate, some of these conditions from actually COVID-19 in some of these wasted children right away. But what I would say, though, and in a more optimistic note, is that we are currently working with a couple of our donors to create a framework for operational research on that and other questions. The hope is to then really reach out and work with as many of you as we can, precisely to enable you to put in place the necessary mechanisms to actually collect some of this evidence rather than assume that this evidence will be naturally available. And so we already have a couple of hospitals in a couple of countries who have expressed an interest in working with us on precisely some of this. So what I would say is that if this is something that your organization is keen to put in place the necessary mechanisms to collect some of this evidence, do reach out to us, because I think yes, over the next few weeks, we'll really be keen to accelerate the launch of multiple sites where we can start collecting some of that evidence more deliberately. Over.
Thanks, Saul and Maya. Staying on the topic of management of SAM and COVID, there was a question that came in regarding, so we know in the case of bacterial infection, it's not recommended to give F100 because it contains iron and it can make the situation worse. But what about COVID-19 infection? Is it advisable to give therapeutic foods that contain iron in its content? Again, I don't think we have an answer to that, but I welcome the panelists to provide their thoughts. Who wants to take a stab at that one? Saul? Maya?
The short end, yeah, from our side, what I would say is we don't know, and I won't speculate. I think it's too early for us.
There was a question. Sorry, go ahead, Maya.
Yeah, sorry, same as, so we don't know, but weigh the risks and benefit. If you don't know what to do, write down what the risks are from one approach and the benefits, and weigh it out. That's the only logical thing maybe to do.
A question came in from Cecile in Ethiopia. So she said the discussion in Ethiopia is that COVID suspected or confirmed SAM cases with medical complications would need to be managed at separate isolation units with COVID. So you'd have stabilization centers set up within your COVID center. What do people think about that? Maya, maybe I'll pass that question to you. Maya?
Sorry, those that have now a stabilization center, maybe they can respond first.
Hatty or James? how is, can you answer that question? Do you want me to repeat it?
Please, I don't know if you can hear me.
Repeat it.
Repeat it, okay. So the question was, in Ethiopia, the discussion now is that if a child with suspected or confirmed COVID and SAM and complications, that they be treated at an isolation, a COVID isolation facility. So the discussion now is that potentially to set up stabilization centers within these COVID units, isolation units.
Yeah, like I was reporting, in Kenya, we only have only 3 cases that are below 15 years. We have not had an under 5 as yet. So I don't have practical experience to share, but I think that is quite critical that within the isolation centers, it will be necessary to have, and actually in Kenya, this is a big gap now, because even training of health workers who are allocated in those isolation centers on anything else is quite challenging. Yeah? But it is, I would say, should be the way to go. However, it would be important that all those who are in the isolation centers be equipped with this information on how to manage some child within that setting. That's what I can say. Over.
Thank you, James. Shifting gears a little bit, one of the questions. Go ahead.
Can I just say,
Maya?
yeah, as a last point on that, I think it's the logic of any infectious disease, which this is so easily transmittable, and even with asymptomatic cases, as we know. So as long as you don't know whether this child, if there are children with COVID, then it's difficult to answer. But if you know there are many infectious diseases in your stabilization center, yes, of course you would separate, just like TB. So you don't want to complicate further, but if you have the space and the resources to do so.
Thanks, Maya. Something that came up in all of the 3 case studies was the use of community volunteers, community health workers, as being a real critical part of the way we can pivot and shift our work. So a question was asked about how do we keep these people mobilized and motivated during the context of COVID-19. So Hatty, I wondered if I could pass that question to you. You had shared about goals experience from the working in other crises. So how did you keep your volunteer teams, community health teams mobilized?
Colleen, we may have to come back to Hatty. I think she's having technical problems at the moment. Maybe you can go on to someone else.
So Mjabuli, I wondered if you can tackle that question, because you shared in your presentation that you are increasing the use of volunteers within the camps because staff access is being scaled down, limited. So what are your approaches to keep your community mobilizers motivated in the midst of this crisis?
Thank you very much. So maybe I must first start with a disclaimer to say within the Rohingya refugee camps, there has not been a single case of COVID so far. So maybe in terms of motivation, our volunteers or facilitators are paid. That's a standard that cuts across all the nutrition sector partners. So for now, I think we have not seen any change in terms of the motivational levels. Of course, we are trying to keep them trained on COVID, to also equip them with sanitizers, to help them to try and also prevent themselves. But in terms of maybe that motivation might fall when the day that we'll start to have actual cases. So this is part of the things that we're discussing with our nutrition sector partners to find ways of how we're going to handle things when they get to that level. I'm sorry, I might not have added much of of maybe useful information in terms of that. Maybe my colleagues may have something else to add.
Yeah.
Thanks, Mjabuli. James, do you have something to add to that?
Yes, and this is a borrowed experience from slightly before COVID. What we realized in ICCM is that when CHVs are equipped and they find value to their community, they are usually motivated by that over and above the remuneration. So in this time when they are given the PPE, they are given commodities which in other circumstances could have been lacking, that in itself, they feel that they are appreciated and they are adding value to their community members. So that showed a lot of motivation. Of course, in Kenya, there has been now gradual increase in terms of their standard payment by government of like say $30. But that is not enough. So supervising them, but of course that means something different now in the context of COVID and over remote supervision. Maybe giving them calls and asking them how they are doing, and then equipping them with the commodities and equipment. Over.
Thank you, James. Another question that came in was regarding the continued use of weight for height measurements. So if it's the case where the government is advising that they want to continue using weight for height measurements, do we think it's okay that that continues if the height boards and scales are disinfected between use? And related to that question, someone asked, has there ever been any work done on investigating whether mothers and caretakers can measure their weight and height of their children on their own? So those are two related questions.
Yeah,
Saul.
so maybe just a couple of quick reactions. Our recommendation right now is that we start moving away from weight for height whenever possible, precisely because I don't think that we can. I think the risks associated with using weight and height equipment at this point are too high to ignore. And I think that I think our feeling is that disinfection after each usage is just not viable, right? And so yes, it would be absolutely necessary if it's being used, but our argument is that it shouldn't. Therefore, the answer is you should not. Now, if you absolutely have to do weight for height, the challenge I think is that even if the mother does it, she's not gonna, unlike the MUAC tape, she's not bringing her own high board or her own weighing pants. So the risk for cross infection, whether she does it or the health worker does it, it continues. So yes, I understand how it limits other risks, but in a sense, once you have made the determination to use weight for high anthropometric equipment, you're already exposing yourself to a lot more risks than if you didn't. So I think that that's an important thing. The other thing, just to say, is that UNICEF right now is about to issue is working on a 1 or 2 pager on precisely the use of anthropometric equipment in the context of COVID-19. So we'll circulate that with the collective just to get your insights and points, but just at some point in the very not too distant future, we'll be actually providing definitive, or at least our definitive position on all of these questions. Over.
Thanks, Saul. Looking at the time, I'm going to wrap up our question period here. I know some of you, we didn't get to the specific question you asked, but I want to assure you that we are going to be gathering these questions. We're going to be putting them forth so they can form the updates of this as we move ahead. So thank you for your questions. If you think of any more before we close, please add them to the chat box, and I'll hand back to Andy.
Thank you, Colleen. Thank you to all of the presenters, Maya, Saul, Mjabuli, James, Hatty, Colleen, and the people behind the scenes, Geraldine and Ben. Thank you so much for your support for the presentations and for the questions. Thank you to all the participants for coming. I would like to just mention that, as I mentioned at the beginning, there is an evaluation for the webinar. If you can click on the link, Ben has just shared it in the chat box. It will take you maximum something around less than 10 minutes, average of 6, and will greatly help improve these webinars. If you would like more, information about anything to do with this webinar, please do. You can send an email to the address in the that's up on the screen right now. We, the TechRRT, will make sure that your question gets to the right person, whether it's a presenter or to the GTAM or to the Global Thematic Working Group on wasting. Otherwise, wishing many thanks for coming. It was a very active environment. I think there were lots of questions that still remain to be answered. As Colleen mentioned, those questions will have been heard and will go into updating the technical briefs and into the questions for further research, etc. So it's not on deaf ears. Thank you. And wishing you all a good day, good afternoon, good evening, and watch your emails for requests for examples, experiences that to be shared, as well as upcoming webinars, probably likely to be one on assessment guidance as well in the context of COVID, as well as in other languages. Spanish, French, and Arabic are in the plans. Thank you.
Thank you, everybody.
If I didn't say, we will share the presentations and the recording, and they will be available on the TechRRT website. I've shared the link during the discussion, but we can share it again, and it will be shared by email. So look out for that too. Thank you.